The major impetus for this study was that in early 2000s, about 2000, between 2000 and 2003, there were new trials coming out showing that particular medications and strategies were extremely effective in preventing complications of atherosclerosis. So particularly medications such as the statin class were suddenly shown to be effective not only in heart disease, but starting to be shown to be effective in stroke and effective in peripheral vascular disease. And those were new findings. So statins were one class of medications. Another class of medications were the medications called ACE inhibitors and ARBs. This is a class of medication that were also shown by the treatment with this to keep atherosclerotic disease at bay. And the complications such as heart attacks, strokes, and cardiovascular death were reduced using these medications. But mostly this was targeted at a population of patients who already had pre-existing heart attacks and strokes. So they weren't really targeted at patients with peripheral arterial disease. A couple of residents and myself started a database and a program. And the idea was the program wasn't just going to focus on just cholesterol or blood pressure, but it focused on it focused on 8 factors. And they included things like exercise, diet, high blood pressure, what your cholesterol was, what your other biochemical risk factors were, how much, what about your diabetes control if that was a factor. So we looked at 8 factors, and we did biochemical and sort of questionnaires, and then we sent a letter to the patients that agreed to enroll in this observational study. And we also sent it to their general practitioners or their primary care doctor. And we said, look, these are the things that you could modify. So we sent it to the patient and we sent it to the doctor. So maybe their blood pressure wasn't very well controlled. Maybe their diabetes wasn't very well controlled. Maybe their cholesterol wasn't controlled. Maybe they weren't getting enough exercise. Their diet was terrible. They didn't quit smoking. So we tried to address all of these risk factors in a comprehensive way. And then we followed these patients along. And initially we were very studious about seeing them every year. But a number of years ago, we decided to try to follow up the whole cohort. So we really enrolled about 459 patients. And, we then looked 7 years later to see what happened to everybody. And we were then trying to see if our program was successful. And because we didn't have a control group, because we offered this to everybody, we couldn't really decide if this was particularly effective. So one of the students in the study, whose name is Dr. Hussain, who's one of our vascular trainees, and Dr. El Omran and Dr. Verma and I said, okay, listen, so to get a control group, we were going to use a statistical test called propensity matching. So we took our patients at the outset, and we went to ISIS and through all of their privacy barriers, and we got it all approved. We basically said we want to try to find a group of patients who would have enrolled between 2004 and 2005, and we want to find patients in Ontario that were seen by vascular surgeons, just like us, but that weren't subjected to this risk factor modification program. So through the statistical manipulations of ISIS, we tried to match one of our patients with 2 patients from around Ontario, and then tried to look at the outcomes. So in other words, was there a reduction in death? Was there a reduction in stroke? Was there a reduction in myocardial infarcts? And what about the outcomes related to their legs? Did they have fewer major amputations? Did they have fewer minor amputations? Did they have more or less operations? And what were the outcomes? And really what we showed with the ISIS data is that the primary outcome, which is a combination of cardiovascular death, stroke, and myocardial infarction were dramatically reduced in our patients compared to the ones in the general population in Ontario. What it says is a relatively small program that addresses these atherosclerotic risk factors can have a profound impact on the patient, not necessarily in the first year, but in all the years going forward. So that's the first thing. The second thing was, not only did we save them from cardiovascular death and those other outcomes, but they had fewer major and minor amputations. It kind of suggests, so that suggests that we are able to arrest the disease that they had and prevent progression in a greater way than our colleagues did around the province. So that's important. The third thing was that we didn't do as many operations on them. So that, because operations have risks, but any therapy has risks. And what we did do is it showed that we did more angioplasty on patients than our colleagues around the province. So it wasn't that we didn't offer them therapy, but we offered them more angioplasty, which is a bit less invasive, and although it has risks, a bit less risky than traditional open surgical repair. Even though we're treating a symptom that the patient comes with, we can't forget to treat the underlying disease, and if we just treat the symptom, we're really not doing the patient the maximum service. Because the maximum service is offering treatment for their very specific complaints, but then saying to them, well, there's a deeper level here, and the deeper level is that the majority of this is caused by atherosclerosis, and that the data that the cardiologists and the stroke physicians are using to treat their patients also applies to you as a patient with peripheral vascular disease. And that's what's really profound about this. Because this is not data that comes from some far-off place in the world or just in America or in Europe. These are Ontario patients, and that if we were to put this in place in a way that was systematic for people who presented with peripheral arterial disease, we could have a much greater impact than just the impact of doing an operation or doing an angioplasty. So the smoking cessation is important. Managing your cholesterol, managing your blood pressure, all those lifestyle issues that we constantly harp on about that are hard to treat, those things are important. Now that we have these results and we can actually discuss them publicly, the question is how to publicize those and how to make it better, not only for our patients that show up and see myself and my colleagues here at UHN, but also how can my colleagues in London and Ottawa or Hamilton or in some small community, how can people do this? So we have to continue to educate both the patient and our family physicians or primary care providers that they have to take some ownership for this. In addition to that, we have to become better at it because every year new studies are coming out such as this now that show that there are benefits to things like exercise and diabetes control of cholesterol, because when we started this program, the level of cholesterol that people targeted has gone down in the 12 years since we started doing this. They used to target a bad cholesterol, an LDL cholesterol of 3.5, and the number has gone down to 2. So that how can we have an impact? Well, the greater impact could be that, this somehow becomes a mandated component of delivering vascular care in Ontario. Whether you deliver it yourself as a vascular surgeon, or you have an internist or a medical physician that works with your patients very aggressively to try to get their diabetes under control, those things are particularly important. And I think that we have to look as a province and say, how could we put in a program that's going to be better for everybody in Ontario and not just in this pocket or in that pocket in some place in Toronto versus everybody in the province. The incidence of peripheral vascular disease is linked to age. So the incidence goes up substantially as you get older, and there are good studies from the United States that have looked on a population-wide basis. So in people less than 45, the incidence is very low, but it becomes up to 14, 15, and higher percentages as you get older. So that's an important thing. So these patients are distributed, and they come to the oncology clinic too. It's just that their focus might be on their oncologic problem and not necessarily on their vascular problem. So I think that these patients are in this institution in everybody's clinic, especially the ones that treat older patients. So it's very prevalent. And the second thing is that a lot of peripheral vascular disease is asymptomatic. It's thought that there may be up to 80 or 90% of patients who have peripheral arterial disease based on a definition, which is an arbitrary definition, but many of them don't have symptoms because maybe their walking is limited by the fact that they can't walk far enough because they're cardiac disease, or they have some orthopedic problem that prevents, they've got a joint replacement or a joint that's sore, so they don't walk that far. So they might not complain of peripheral arterial disease, but it doesn't mean that they don't still have it. So we think that the burden of atherosclerosis is actually much higher. And as we see new research come out at various different meetings showing that, in fact, the impact of lowering cholesterol and some of these other things is extremely important in broader ranges, then there's probably a bigger portion of the population that we need to be targeting. So we think that the burden of atherosclerosis is actually much higher. And as we see new research come out at various different meetings showing that, in fact, the impact of lowering cholesterol and some of these other things is extremely important in broader ranges, then there's probably a bigger portion of the population that we need to be targeting than just the population we targeted here, because we targeted the patients that came to our door. If you're a general practitioner, there are many patients who may have peripheral vascular disease or may have minor symptoms that the GP may treat medically before they even come to us. So probably the people that we have treated are the tip of the iceberg and not the vast population of people that are out there. Every patient has to take some ownership for their disease. So they have to take account for they have hypertension or high cholesterol. They need their doctor to help them manage that. But there are things that they can do. Things like exercise, weight loss. Not easy to do, but there are ways to lose weight. Control of your diabetes, control of your hypertension. Get yourself a blood pressure cuff. Measure your blood pressure. If your blood pressure is out of control, take those readings to your doctor and work with him or her to get your blood pressure under control. We know that some of those simple things, diet, smoking cessation, so that everybody has to take a little bit of ownership for their own health. But take some ownership. Make a change for, cut down your smoking, quit smoking. Get to your doctor and say, I want to quit. What can you do to help? I want to have better blood pressure control. I want to have better diabetes control. Let's work on it together. Maybe the primary care physician doesn't necessarily have all of the answers. They need some help from various specialists or various programs. But I think for the individual patient, you have to take ownership of this. This is your disease, and we can help you manage it. But we're going to be better at it if you're going to make some efforts on your own.